morning, everyone. My name is Dr. György Gulácsi, and my PhD thesis is the use of novel MRI techniques in the diagnosis of chondrogenic bone tumors. I work at the Medical Imaging Center at Semmelweis University. I'm a PhD student and an MSK radiologist there, and my vision is to provide state-of-the-art diagnostic care for patients with bone and soft tissue tumors. And my mission is to determine the optimal imaging algorithm of chondrogenic bone tumors that can eventuate higher clinical decision-making efficacy. Here you can see my specific goals and my two ongoing projects that I will show you in a detailed manner. So my first topic is investigating the diagnostic accuracy of advanced MRI techniques in patients with cartilage-forming bone tumors. So basically, chondroid tumors, all in all, are quite common, and the majority of these chondroid bone tumors are benign. But a small minority of these neoplastic lesions are malignant, and the accurate grading of these tumors are needed because the appropriate therapy differs greatly among the different tumor grades. For example, for enchondromas, the benign version of the chondroid tumors, it is only wait and see in most of the cases. And for low-grade chondroid sarcoma and high-grade chondrosarcoma, it needs surgical therapy, and the surgical therapy itself depends on the grade of the tumor. And what is the problem with this? The problem with this is that the preoperative diagnosis is not so straightforward. It is a very challenging task for the clinician, the pathologist, and also the radiologist to grade these tumors reliably. And conventional MRI protocols, which is the highest order of imaging technique as far as the chondroid tumor imaging is concerned, are not accurate enough. As you can see, its accuracy is between 60 to 80% all in all, and false positive cases are quite common. And lately, relatively new techniques come up and were started to be used in sarcoma imaging, and we would like to see how these new techniques can result, if these new techniques can result in better patient management, better patient diagnosis. So our clinical question is, what is the diagnostic accuracy of these new techniques, and compare them with the conventional MRI sequences as far as the accuracy of grading these tumors. We use the PERD model because this is a diagnostic test, and the patient population is patients with verified chondroid tumors. The index tests are DC, which is called dynamic contrast enhanced imaging, DWI, which is diffusion weighted imaging, and radiomics. The reference test is conventional MRI, of course, and the diagnosis is cartilage forming bone tumors, and we would like to divide those bone tumors into benign, low-grade, and high-grade malignant lesions. And our hypothesis is that these emerging new techniques perform better compared to the conventional MRI techniques in grading these tumors. And the clinical implication, of course, is better preoperative clinical radiological decision-making in the treatment of these kind of tumors. We did the systematic search, as you can see, with the search key that can be seen below. And the flowchart of selection can be seen here. We included only 12 articles in the end. And these 12 articles can be divided into three groups, of course: the radiomics, the DC, and the DWR MRI techniques. And as you can see, we found only 2 and 1 DC and DWI techniques, so that these techniques are not, these articles are not enough to do a meta-analysis in these two techniques, so we included only radiomics in the meta-analytical part of our research. So, what were the outcomes? We compared the benign versus malignant lesions. We compared the benign versus low-grade malignant lesions and the low-grade versus high-grade malignant lesions, how we can differentiate between these entities. And the outcome measures were accuracy, sensitivity, and area under the curve. And as you can see in the radiomics analysis, we could only do it in the benign versus malignant differentiation because there was no enough data comparing benign versus low-grade malignant and low-grade versus high-grade malignant lesions. And as I mentioned before, we had no enough data for the DC and DWI techniques, so we couldn't do the comparison. And here you can see our forest plots, which is a comparison of sensitivity, which can be seen at the left side of the image, and the specificity of the radiomics and the conventional MRI analysis for benign versus malignant tumor differentiation. We did a subgrouping of 4. We created 4 subgroups. 3 was created by radiomics analysis, and the one was the conventional MRI, which is the expert group shown here. And we also compared the subgroups to each other and also compared the expert or the conventional MRI technique with this new method, which is called radiomics. As you can see, because it's a tumor, we would like to have high sensitivity and relatively high specificity, but in tumor imaging, it is better to have a higher sensitivity as a higher specificity. And as you can see here, the expert subgroup performed very poorly, so the radiologists were not up to the task in order to perform a good sensitivity for differentiating between the benign and the malignant tumors. And the other subgroups, for example, the T1 weighted, T2 weighted, and the other, performed better. T1 weighted, T2 weighted, and other are the sequences that were used for the radiomics analysis. So we subgrouped into the radiomics analysis by which sequences it used for the differentiation. And unfortunately, it is not shown here, but we didn't have any significant statistical significance. So there was no statistical significant difference among the groups, neither for sensitivity nor for specificity, unfortunately. And here you can see our area under the curve analysis and the subgroup comparison for the radiomics-based prediction models. So what are the strengths of our analysis? We used a very rigorous method selection criteria and very rigorous article and inclusion-exclusion criteria. That's why we had so low number of articles. We could only use 3 articles of those 9 articles that I showed you before of the radiomical side. And we also added radiomics quality score, but that wasn't included in our presentation. The limitations, of course, the small sample size, the low quality of results reporting, and the partially overlapping patient population, unfortunately. And what is the conclusion? We have insufficient number of articles with uncertain results, of course, the poor quality of radiomical analysis, and flawed overall methodology. This is my first project progress. And in just in a few seconds, I would like to introduce my second topic, which is basically a retrospective diagnostic test study of my first topic. So we would like to have a research of our own on this topic. And because the scarcity of the time, I just say a few words about the background. And we would like to use our National Bone Tumor Registry, and from those patients we would like to conduct research of our own to add some radiomics data into that pool that I just showed you. So the question is basically the same as in the meta-analysis, and the clinical implication is also, and I would like to thank you for your attention, and the quote that I wanted to share you is from Walter: the more I read, the more I acquire, the more certain that I know nothing. Thank you very much.
I might have a question regarding to the diagnosis. It was not clear for me that diagnosing those tumors, if they are benign or malignant, is in the first line based on only imaging techniques. So why don't you just get a biopsy and get 100%, almost 100% sensitivity instead of those models?
Because in this case, even biopsy is not close to 100%, because the biopsy depends on several factors, but the most important factor is from which site the tissue was collected. And sometimes it is very hard to decide from where the biopsy sample should be collected. And sometimes we have false negative results of those histology because the sample collection was not from the proper place. And even with imaging, it is very hard to determine the exact location from where we can collect representative sample from the tumor. So in this regard, preoperative histology is not as accurate as in compared to other sites in the body. So that's exactly why we need better imaging.
Okay, may I ask you what the total number is the chondrogenic tumors in Hungary? This is my first question.
Total number, its prevalence is 2 to 3% of all. So basically, we have 200,000 to 300,000 in the whole population. But the incidence is 1 in 200,000. So it is quite a rare tumor, the malignant counterpart. So we can just calculate the numbers that it's in the hundred. It's in the hundreds, so it's few hundred cases in each year. The chondrosarcoma, and it is also included the low-grade chondrosarcoma, which has some resemblance for enchondroma. So it's a very, very common tumor, the benign one, but it's kind of rare one of the malignant counterpart.
So what would your recommendation be for the upgrading of MRI instruments? Because there is a huge development in imaging techniques, but it is costly, it is very expensive. So how many MRIs should be upgraded to this technique?
I don't think I think the technical level of the today's MRI in Hungary is not the problem in this case, because if you can recall, our radiomics analysis, it only used conventional sequences, which can be done with an absolutely average machine. But these so-called emerging techniques are not that novel right now. So, and even an average MRI system knows those sequences, but unfortunately, it is not widely used. So it is not the technique, I think, which is not available for us, but in clinical practice, it is not that widely used, the DWI and the DC MRI. And unfortunately, even in other countries, it is not very commonly used techniques. That's why we have so small amount of papers on this regard.
Okay, thank you very much.